it is our pleasure to have right now over 130 people live here, but many of them registered around the world. We're close to our maximum capacity. So recording will be in a library. So I can pass you the microphone, Hagit. Your lecture is very welcome. I'll disappear, but I will be back for the Q&A part.
Okay, thank you, Andrea. Thank you very much. That was a great altogether intro and tutorial. And yes, I'm also welcoming you from month to month. We have more videos and more videos available. So you already been introduced to that. Let me know if my internet is unstable, then I may move a place. But if so far it's okay, then let me know. I'm going to share my screen now. Okay. And I'm going to minimize something here. Fine. Okay, so welcome everybody. And
Can you
thank
put
you
it on
for
the presenter mode, so everybody can see the full slide? Should be.
No. It's actually on purpose like that because sometimes I need to go up and down. So I think it's going to stay like that. Yeah.
Can you make it a little bit higher because we don't see the bottom of your slide? Move it higher on your screen. Oh, this is fine too, yeah. But
This
the
is okay?
larger the slide, the better. So make it a little bit larger.
No.
Okay.
This one, for example.
Yeah, okay. I guess you keep it like that. Okay.
It's okay? It's okay?
Yeah, that's fine.
Okay. So the first, basically, I prepared about 3 different topics that I find when I teach the short courses, level 1, and then practical 1 and practical 2. There's always maybe difficulties, I don't know what's the right word, stress also and tension about these topics, starting with the really understanding what is this shoulder counter traction, or you can also say counter tension, is all about, how precise we really need to be about it, what it represents, what the meaning of it, why we teaching it, and I know it's a lot of vectors and forces and many times confusing, but to understand why we're teaching it and what actually you are going to do with it in the clinical application of it. So I will see how long it takes us because this is a flowing presentation. And in case I will not finish the 3 topics, I promise to come back. I try to come back even in May to finish it one more time. The second topic is I wanted to talk about the radiological curve type and the subtype criteria that presented by Rigo and Mina in the paper. I think the latest I have is in 2017. Basically, nothing really changed. These are the subtype. And what are the importance of these subtype into the best correction and traction belt placement and certain exercises? I think it's a very nice, good topic. And the last one is I wanted to talk about the upper or the proximal thoracic. Also, what to do, what can we do about it, how much can we do about it. So these are, I think, many times topics that come back again and again. Maybe because, yeah, it requires, in general, more practice and more comprehension about, for example, these topics. But I want to really say from the bottom of my heart, and I usually say to all my students, it takes years without being anxious or disappointed. It takes years to become comfortable, almost complete understanding. We never totally understand, but maybe comfortable in your skills that to know and understand at least what we teach. And it takes meetings and meetings and meetings again, and listening to the material again and again. This is how I studied it, by listening. I was for Dr. Rigaud for years. And every time something is opened up, a better understanding about something. So we'll start with the upper thoracic, proximal thoracic. And say in general, it's a very nice statement, the shoulder girdle or the upper thoracic region, which is here on the left, and the pelvic girdle are really the postural buffer systems. First, we need to align the shoulder, upper thoracic girdle, and the pelvis in its best alignment for each curve and body, and in between where we're going to do the rest of the torso reshaping. So to understand, this is it's not about the shoulder traction here, but it is the preview, it is the mindset, it is the importance that by creating the body, aligning the blocks from the bottom up, and then coming to the point where your trunk is to its best, open side to side, up and down, front and back, you can say too. But right now we are looking from the back. And the shoulder traction and shoulder counter traction is a frontal plane maneuvers of vectors and forces, or it is even, I think what I can say, it's the beginning, but also the end, and you will understand in a moment, the end of the frontal plane torso reshaping. With it, of course, we have our axial elongation and sagittal plane correction that we are doing before. But when it comes to the shoulder traction, understanding what are we doing there, it is the beginning and the end of vectors of alignment that starts from the pelvis, going upwards towards the upper thoracic region, making sure that in the frontal plane, all the correction of the lumbar and the thoracic and the upper thoracic, if exist, is to create the best. This is like a yoga block on the right side, to create the best endless line, with endless line, running across the body from side to side, from the bottom to the top, and maintaining this basically represent an expansion of the trunk to its maximum. And when I said that the shoulder traction or this area, upper thoracic, is at the beginning, at the end, so from the beginning, from the 3D postural correction made first, where we use movement to align the trunk over the pelvis and the head over the trunk and over the pelvis as centered as possible. Or if we have some special maneuver in a 3C, the diagonal traction line, then also aligning still the right side and the left side parallel to each other, and the top and the bottom parallel to each other. I'm spending time here because this is very, very important. When I teach, whoever here is my student, you know that we are talking about, and I'm not really letting you go until I see a full trunk expansion, that there are no folds in the bra or the skin or the or the shirt if it covers, that you are doing your maximum to expand the concavities wherever they are, in the frontal or sagittal plane, but right now we're in the frontal. So from the beginning, pelvis stable, going up the trunk, and ending with the upper thoracic expansion side to side, the region above the bra for girls, or you can say from the level of the armpits to the neck area. This is the upper thoracic region. And the upper thoracic region, as I stated before, as it is a buffer to the alignment inside between the upper thoracic and the pelvis. Therefore, we have to, from the beginning, make sure that the patient is expanding their upper thoracic to its best, leveling the shoulders parallel to the pelvis, and the pelvis will be parallel to the floor or the sitting or to the bar if you lie down or prone on knees. But no elevation, no rotations, and really fully with the scapula in its best physiological position, really fully nicely. So if you think about that, and if you are able generally to maintain the trunk super stable like that after the 3D positioning, and the upper thoracic level, open, expanded, and not moving either, then you can say that really later on during the muscle activation, where we increase traction, tension, pressure inside the trunk and requiring more correction from the patient, which when we ask from them more corrections, they should not move any body parts. The movement finished after 3D positioning. But we see many times when we are encouraging the patient, and the patient is an encouraged patient and with motivation, they are going to increase their tension in the lumbar to correct it towards the concavity, to expand it, or increase their pressure in the thoracic on the right side towards the left. And we may see responses to these overthinking or enthusiastic, don't call it over, enthusiastic correction, then we see compensations. We see that the patient is not able to maintain this expanded trunk. There are going to be some collapses, actually, usually in the opposite side of the concavities. Because if a person with the left lumbar will start to be enthusiastic and move the lumbar to the right too much, then the left lumbar can collapse and the ribs above it will collapse. And the opposite way is if the patient is over or enthusiastic about moving the thoracic from right to left. And all of a sudden we see some collapse of the right convexity because they are overdoing it to the left. And the right shoulder drops down and the head started to tilt to the right. We see these compensations coming. And when do they come? They come during the muscle activation phase, during torso reshaping. And they come because the patient is being encouraged by us and by themselves to increase the correction, the corrective vectors that we teach them during the exercise. We demand weak point, weak side, expand, 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 and we demand. So then come the shoulder counter traction or tension in order to control this compensation that will come, will appear, we see them. and assist the patient to maintain the lumbar stable, the thoracic stable, and the upper thoracic stable. So we're going to go over that. This is just a few pictures to show not exercising, exercising. What I was talking about, the rectangle shape of the trunk, fully open, fully engaged. This is what we are aiming for. So in this patient or in this patient, you can see that what I'm asking is that she will create, this is a little bit with diagonal traction line to the left, but I need to demand that all her trunk, the muscles, will be open and stretched and expanded and like a rectangle, endless lines, holding to poles or holding anything else, and not to move nothing, not to move millimeter. And then, we increasing the demands and we working and coming to the tension of 12 time, and the patient will be enthusiastic to do more. But we need to control that we are not going to lose this body positioning. Even just in standing in front of a mirror. So we're going to start with a 3C. And maybe a moment before that, this is a very simple table talking about the shoulder counter traction in terms of who does what. And I always see the 3C and the 3-4C, or as other school knows by non-3, non-4 curve type. One moment. This is a primary thoracic curve types. They can be with lumbar or without lumbar. Those two are they will always practice shoulder counter traction on the thoracic prominent side, mainly only, let's say only, on one curve type, maybe can have something else, subtype, but this is it. The 3C and the 3-4C, that's like only on the thoracic prominent side, and I will explain why. And then the 4C and the single lumbar or thoracolumbar, which consider to be basically a lumbar region curve, the single, and they are both primary lumbar curves. The 4C have both thoracic and lumbar. And this is the only curve, if you think about it, 4C, that have thoracic and lumbar in it, for sure. And the single lumbar or single thoracolumbar only have lumbar. So these are both primary lumbar. And they're practicing shoulder counter traction on both the thoracic prominent side and on the weak side, on both sides bilaterally. Okay, so we said that the shoulder counter traction comes during torso reshaping phase, which is the phase that there is no movement inside the trunk. We finished after the 3D postural correction. Now we are doing reshaping of the torso with expansion and muscle activation. So when we come to muscle activation and we ask the patient to perform more correction, then we introducing or emphasizing the shoulder counter tractions. So let's start, as I said, with the 3C. And just for the explanation, the purpose is to maintain, and this is important, the purpose of the shoulder counter traction on the thoracic prominent side is to maintain the upper thoracic, this region, proximal block basically, and also the main thoracic, which I'll show in a moment, in their best stable position. So there are actually two reasons or two compensation that we are going to see that we need this on the right side. The definition of the shoulder countertraction is basically a strategy of muscle activation in the frontal plane on the convex thoracic side, where the upper and the main thoracic blocks working together in opposition. I will go into details of the vectors soon, but this is just a general definition. Effectively assisting in the expansion and the tension of the weak side, right here on the thoracic concavity, the weak side. We, as you know, working from expansions and not from so much from contraction of prominences. In the past, yes. In the past, I want to say maybe 2 decades ago, or in the days of Katarina and Krista Schroth, there was more emphasis on working from the prominences, meaning to tell the patient to contract the prominence either forward or from outside towards the middle. We handle the patient on the convexities, but it changed quite a long time ago that we are focusing more on expansions of the concavities. It doesn't mean that you cannot direct the patient, that you cannot instruct them, show them the maneuvers, where they're going to. But later on, I don't really, from session 2 or 3, I don't emphasize on the contractions, the concentric contraction of the prominences, but on the expansions of the concavities, not the convexities. We're working on the concavities. In the frontal plane, it's going to be here, towards the left side in the thoracic, or if there is a lumbar on the left, towards the right side. So that's why we are referring more for expansions. But since in the old days, in the templates of the Schroth family, the shoulder countertraction was just like that. Or if you want to see it in the template, it looks like that. Probably you're all familiar with it. In a 3C template, shoulder countertraction is on the thoracic prominent side, and basically it represents contraction later of the convexity towards expansion of the thoracic concavity. So in a sense, it's the same direction. Do not worry, do not bother. Is it on the convex side, or how come you refer it to the expansion of the weak side, then it's on the left side? The definition is shoulder countertraction on the thoracic prominent side. This is the original, the authentic description and picture. We are today referring it shoulder countertraction on the thoracic prominent side for sure, but we need to know that it is also due to expansion that we are directing more the patients. But it's the same, and it's going to be referred to what's happening in the thoracic. So I'll go back to this one. We'll talk, I think, let's say it divided into the shoulder traction and the counter. Now here also there's always question about who is the shoulder traction, who is the counter traction or the counter action or the counter tension. And Shoulder traction, it's simple. It's a shoulder, it's in this area, it's traction of the upper thoracic region here on the right side. Basically, we can read it as an action in the upper proximal thoracic block consisting of isometric, because there's really no movement, because we are already in the muscle activation, there's no movement. Isometric traction and tension in a medial to lateral from the center towards lateral direction that starts at the shoulder block with the scapula in its best physiological position. So even here, I always see in my courses that not always we positioning each other or the patient with the shoulder blades in its best position. So you want to see that the scapula is not sticking out to your eyes, or there is a bulginess there, or there is a winging. You want to create, like you can see here on this body, no prominences appearing. And usually is if you are going to bring the arms in this 30-degree from the horizon, a little bit forward, the elbows, the arms, and the scapula will sit properly. Those of you who recognize or will pay attention, if the arms go behind the line of the shoulders, or sometimes even in the line of the shoulders, or behind, then you will see the scapula winging and not giving you the best fluid trunk shape in the back. That is very important. The shoulder traction, aiming, we said it, and I'm going to go over it so it will be more explanatory. So this is the shoulder traction. We take it, the upper thoracic, from the center to the right side with an attempt to counteract some compensation here in the upper thoracic in a moment. The counter is a counteraction in the main thoracic block. Historically, as I told you, it was contracting of the prominence from the right side to the left. And when they contracted the thoracic here, I want to show it with my slide soon, but it refers to here, starting from here. So really it's aiming to maintain the thoracic block stable, this action also, and preventing it from shifting laterally towards the convex thoracic side if we do too much shoulder traction. So there is always, it's going to be a cycle going, what we're doing more, where we need to correct, compensate. But if we do too much shoulder traction to the right, then the thoracic prominence will shift back to the right. So then we need to counter it with action. So it's a cycle like that. And it really doesn't matter if you call all this maneuver shoulder counter traction, if you understand it. One goes this way, correcting something. The other one goes here. And by doing these two forces against each other, if you applying the same traction and pressure, you will maintain basically the main thoracic in its place and the upper thoracic in its place, and that's what matters. So this is a person with a 3C. Her type is subtype is A1. There is no lumbar in her spine. And we have, you can see here the transitional point between the thoracic region and the lumbar region, TP, transitional point. You can see the, what I call the stop point, SP point, above her bra. Basically, it is in the same level, should be with the upper and vertebra of the main thoracic, this black rectangle diagonal. And we're starting to explain the correction of 3C and why we are doing what we're going to do. So 3C start with third pelvis correction from the bottom in the frontal plane. Third pelvis correction from left towards the center first. And then depends who, some will go over correction to the right side. At the same time that the third pelvis correction happening, and let's say the person is going to do the 3D correction and then sustain it. At the same time, we have also axial elongation, which maybe not even before. Axial elongation is our number one, okay? So, but here for the explanation of this shoulder countertraction topic, I'm not talking about the orders of what we're doing. I'm just telling that with the third pelvis correction for the pelvis in the frontal plane, along with axial elongation, if we connect the two arrows, the purple arrows points, we see that a diagonal traction line, basically from here to here, will be formed naturally by itself. It's not something that we are forcing and telling the patient, okay, take your body and climb and go in the diagonal traction way, which took me also many years, and then listening and understanding Rigo, it is a consequence. The diagonal traction line is a consequence of third pelvis correction and axial elongation, particularly if the pelvis will move from the center more to the right and the trunk from the center more to the left. Then we have two arrows that if you connect between them, it's the diagonal traction line. And typically it should cross at the transitional point between the thoracic region and the lumbar region. And all the thoracic basically is being called to go and open and expand itself on this diagonal traction line. It's a very particular line for a 3C type curve only. It's a line that can happen because of the overcorrection of the pelvis from right to left, from left to right, sorry, and correction of the trunk from the right to the left. It doesn't happen in any other curve where we're maintaining the body, in the center. So you really need those two components. Pelvis overcorrect to the right, trunk will overcorrect to the left. And then with axial elongation, this is happening. Thoracic start to expand, the patient start to expand and expand and expand, going and going until they can create the best. This is the same girl, that's her, and that's her where she, in the same year, where she's just a very flexible, she's a hip hop dancer. Those of you who study with me, I think you know her. So she able to expand her thoracic. Maybe I'll take this picture from here and I'll put it here on the side so we can always refer to. Able to expand, to take the pelvis a little bit to the right, level it. We must make sure that she level it. Upper thoracic, you can see the right shoulder in a clinical picture is low than the left. Now we're doing some maneuvers and we need to keep it leveled. Still the left one is higher to my satisfaction, but okay, it needs to be leveled. Parallel line, right and left, even though these lines are on a diagonal, they need to be parallel to each other, as much as parallel to basically the diagonal traction line here. and pelvis and the bra and the upper thoracic all needs to be also parallel to each other. And this is a desired correction, basically, but it's not always happening like that. What's happening? Compensation number one. If I take the same girl from before, maybe I again will take her picture, copy, and I'll put her here. One moment. So common compensation number one that we see, this is not inactive, but let's say imagine she was even active and then increasing her correction from the right to the left during muscle activation when I demand more expansion of the concavity, thoracic concavity. Then we see, I call it in my courses, a banana being formed. It's not a rectangle, it's not a parallel, it's something like that. This is overcorrection of the main thoracic that may create collapses of the ribs in the main thoracic region, in the main thoracic curve, at the thoracic prominence side. Okay? And we see this happening. Compensation number two will come also from this, if there is this overcorrection from right to left, we can see that the weak side expansion, if it goes beyond the main thoracic level, above the stop point that you see, the point, the circle in her shoulder blade left, if her opening, her correction will go, and you can see that she has some ribs on the right side falling, and then more overcorrection, it climbs up and come into the level of the upper thoracic. And then what we can notice is it's not really a creation of upper thoracic. It takes months and years to really have, if there is the genetic for this curve type upper thoracic. But it will create a compensatory, if any of you here will take their left side arm and open right now, open your ribs in the frontal plane under your left arm as much as you really can, you should notice that your ribs on the right side are collapsed and that your head and neck, or neck and head, are also side bending towards your right side, and you're getting some upper thoracic compensation number two here. So we can see here that the patient probably inside herself, not really this one, this is it's just a picture, but a patient can do that and create those two compensation in a thoracic correction, when someone is trying to correct their thoracic region, and this will go with all four curve types. So I want you to be familiar with those two compensation happening if you are trying, over trying, enthusiastic about, when you are correcting your main thoracic from the right to the left and you crossing the stop point and your right side will start to collapse, the ribs, and your upper thoracic will come up, any curve type that have thoracic will have these common compensations. So in order to correct these number one and number two compensation, very simple, we want to lift, look at this, we want to lift these ribs on number one to here. And later we want to correct the upper thoracic as well. If you add a shoulder traction on the right side, and if you do it yourself too, the shoulder traction, first of all, while we are lifting the arm up on the right side, just by lifting the arm up, you are elevating the ribs. And then if you ask the patient in the horizontal plane, laterally, to traction the shoulder, then it's not just about what it does basically the muscles that cover the ribs on the right side. Is it the serratus anterior? Is it in certain points maybe also the trapezius, the latissimus dorsi, the big muscles that hover around the convex side? Once you lift the right arm and you push basically your armpit, from the armpit area, any muscles in this armpit right side area, while the arm is holding a pole or on the shoulder, just holding yourself, the latissimus dorsi and the muscles that are attached to the greater tubercle in the shoulder, okay? All these muscles that attach to the greater tubercle in the shoulder region, when you move, you're not really moving, but when you're creating this tension, one, for the main thoracic region, it lifts the ribs. The muscles get tension and traction upwards and then lateral, and it holds the ribs up. And then the area of the upper thoracic region, by applying the force, calling the spine, you can see that the arrows of the shoulder traction here are calling the upper thoracic curve as a compensatory that happened. It's calling it the traction there, the pressure laterally will pull the spine towards the scapula on the right side. So if you look from here to the next step, you will see the red line become straighter. You see the upper thoracic getting pulled towards the center of the body and the rib cage being lifted. The patient will now continue this cycle, expanding the left side, this is the counter, and expanding shoulder traction to the right side. And all the time, this cycle it's called on the thoracic prominence side, but you can see it really refers, it's doing correction throughout, but it will keep the main thoracic ribs on the right side elevated and the upper thoracic leveled, and this is the aim of this shoulder counter traction on the thoracic prominence side when we're correcting the main thoracic, the thoracic curve, the compensation that appears, and then the cycle of two compensation and how we correct them. And that's it. Stay there. Encourage more expansion on the left side. You see the ribs, God forbid, dropping. Again, shoulder traction, lift it and lift it. They continue to do expansion on the left side, but again, they are falling and you see upper thoracicum. Again, re-encourage shoulder traction and correct these two compensations. So you can see this is the circle around That's the shoulder counter traction on the thoracic prominent side. This is how it is in the template. On the left side is a curve without a lumbar. I didn't paint a lumbar there. On the right side is a 3C with a lumbar, like A3 subtype. But 3C is a primary thoracic. The patient does its correction, its work, its everything really on the thoracic curve. This is the main problem. Two subcurve of 3C don't even have a lumbar. So many times I don't even correct any lumbar there. I just manage that nothing will get worse. But there is no lumbar, so I don't need to correct the lumbar. And in the last type, A3 type, which is here on the right side, I will pay attention to the lumbar, fine. I will manage it. I will take care of it. But again, the main purpose of 3C is to correct the thoracic curve, and the main compensations we see related to the correction of the main thoracic curve: one, rib falling; two, upper thoracic creation or exacerbation. And that's why 3C performing the correction it needs to, the traction on the right side. There is no need to do anything on the left. Nothing right now for this curve. I will take questions before I move to the next curve type.
I think it's better if you keep continue. I've been answering the questions related SP, people asking what is the stopping point exactly. So maybe you can comment on that. And then no other questions related to the presentation.
Okay. So Andrea, if you feel that, I also feel fine to continue, but if you need to stop me, something very special, let me know.
Will do.
Okay, so we go to the next curve type. We call it an SSOL 34C. It's equivalent to those of you from BSPTS or others who knows as a non-3, non-4. Basically, we're talking about the curve that is with the transitional point on the central sacral line. Traditionally or not traditionally, I wanted to say that primarily we see this is as a balanced curve or curves. Balance because the trunk is on top of the pelvis. We don't see really a pelvic shift. There is the naming, there is a 3 here and there is a 4C. And basically, what we recognize from this curve type is that sometime maybe we see the pelvis a little bit more to the left and represent like more close to a 3C. Sometimes we see it more to the right, maybe elevated on the right, maybe rotated posteriorly on the right, like a 4C. Sometimes even the curves, this curve type is also a primary thoracic curve, and it can come with a lumbar or without a lumbar. These are your two subtypes, a C1 without a lumbar and C2 with a lumbar. But it's a primary thoracic. But sometimes we see that the lumbar is actually bigger or with more curve or with more rotation, acting like a little bit like a 4C. Sometimes we see the thoracic and maybe the pelvis to the left. So, but in general, appreciation of the curve type and the body, we are always debating. And when you are debating, you know this cliche, when there is a doubt, no doubt. So name it like that and keep it balanced until you see differently. So when I come basically to this curve type, I look at it and I also remember it took, again, certain things really click years after. But I remember Rigo saying, and it's true, that the lumbar and the pelvis in this curve type, generally can be corrected or maintained, actually, not even corrected, let's say maintained stable by the axial elongation. You don't really need to rotate it or to level it if you don't see something. And even if there is a lumbar, even if it's a C-type subtype, C2 subtype, meaning this curve with a lumbar, if you, because it is underneath the trunk and the head in the center, if you maintain, you know how to have your patient maintain and you manage it stable and only encourage your axial elongation, you basically taking care of the lumbar. You don't need to emphasize more on the lumbar, even though if you have a lumbar, unless it's something extraordinary and you cannot manage, then you are expanding the weak point and all of that. But generally, and this is really for more advanced clinician who will take it now and try it in the clinic, you keep it stable. The axial elongation is enough to control the lumbar, to stretch it, whatever it needs to be. And then the patient is focusing again on the thoracic region correction. And therefore, and because of that, it's also acting the shoulder counter traction like a 3C. Only shoulder counter traction on the thoracic prominent side. Because we are dealing here with a maneuver, a correction, a main correction, an emphasis correction of the thoracic. This is a thoracic primary curve. And then come the compensation exactly as you saw in the 3C. So this is how it's basically happening. Here, we're encouraging the thoracic, stable the pelvis all the time. You don't let go. You manage. This is my words and my emphasis. I'm not letting the lumbar get worse. I will manage it, but I don't need to do much emphasis on it. One, because one of these two curves, C1, don't even have a lumbar. So if I come to a C2 and I have a lumbar, I will traction, I will elongate. Then the lumbar get its best correction. Yes, I want to say I'm telling you, but you will experience yourself. And you will start to encourage the patient to correct their main thoracic curve. As they correct their main thoracic curve, we may see the same thing we saw with the 3C. Overcorrection of the thoracic from right to left, like a banana creation and falling of the ribs on the right side. Now, what is so, why it is a bother that the ribs on the right side are falling, and why, and that she become basically, she or the one I show you before, mirroring her template of curve from right to left. One can think, yeah, maybe it's a good thing. And I know that in some methods, and I see some pictures over the media with patients pushing their curve from right to left and creating these collapsed ribs on the right side, and all the curve just shift to the left and thinking it's good. No, it's not. Why it's not good to have now the ribs collapse on the right? Because if the ribs collapse in the frontal plane, they are going to collapse in a circular way all the way on the right side to the sternum. So the ribs are, a semicircle on the right side from the spine to the sternum. When they are collapsed, they are also collapsing the front of the patient. If they collapse in the ventral flat zone, in front of the thoracic prominence on the right side, the patient will never be able to expand the ventral flat zone forward and upwards and allow the thoracic prominence from the back in the sagittal plane to go forward and upwards, but forward. And then there's not going to be the torsion of the torso, of the ribs, sorry, the ribs, because we don't move the torso, the torsion of the ribs that comes, the torsion of the rib cage is from sagittal plane correction along with axial elongation. But if the sagittal plane will be compromised because of the rib collapse in the frontal plane, the patient will never get its best or at all correction. So just moving the spine from right to left, overcorrecting and collapsing the ribs is not ever good. So we have this compensation, and we may have the same deal of upper thoracic compensation. If the ribs collapse on the right, you just, while you're sitting here, everybody, if you are going, just do it. Drop your right shoulder down like you are collapsing the ribs on the right and expanding your ribs to the left. And you see that your head is side bend towards your right side, creating thoracic curve, unleveling of the shoulders, and the same we explain for a 3C. So those two compensations will get shoulder traction, and then the upper thoracic will be pulled towards the center, and the ribs will be elevated from the same reasoning I explained before, and the patient get its best correction. Here she's not holding the pose. It's a picture, I don't have someone, but this is the idea. So it's exactly for the same purpose as 3C, the same compensation, the same shoulder canal traction on the right side. And this is the template, basically, with a lumbar or without a lumbar. Same shoulder counter traction on the right side. Okay. I will go to the 4C. Now we are talking about bilateral shoulder counter traction. And let's explain this. This might be the, no choice, it's bilateral, so there are multiple directions. Usually this is maybe the most complicated, but bear with me and put in your mind the goal that we said at the beginning of this hour, that we want to have best expansion of the trunk, including the rib, the lumbar, the upper thoracic, and that's what we're trying to keep. So in a 4C, since we definitely have two curves, and now we're shifting gear that the lumbar is the primary curve, then to see what about correcting the lumbar brings the need for bilateral shoulder counter traction or bilateral shoulder traction to compensate for the compensations. So we see here a 4C patient. She will start to move her pelvis from the right, third pelvis correction, towards the center. And Keep it there. Always elongation, axial caudal elongation. Then the next. Her next climbing up from the pelvis is the lumbar. The lumbar as a primary, as the main focus. The patient will want to expand the weak point on the right side, the concavity of the lumbar, in order to pull the spine, the white line, the lumbar curve, to come towards the laser line, represent the central sacral line center. So the patient expanding and expanding, and what we can start to see that as the patient expanding the lumbar, many of them, I start to see increase of the thoracic curve to the right. Imagine yourself now while you're sitting. Take your lumbar left, put your hand on your lumbar left side, shift it, just that, it's okay. Shift it like you want to expand the lower ribs on your right side. Shift the lumbar from the left to the right and see how you, even without a thoracic, your thoracic ribs are starting to flare up to the right side. Of course, we don't want the patient to move, no question about it. But in order to represent to you the action that is going to be taken care in their body, when they are contracting the lumbar on the left or expanding the concavity on the right, it's almost hard to escape this compensation of the 12 rib coming up, the 11 rib coming up, the 10 rib, the 9th rib. Basically, the thoracic is starting to stick out to the right side. Yes, we're going to have a right bed. Yes, we're going to have we're going to be on top of the patient and we will tell them, hey, be aware. Don't overdo the lumbar and allow the thoracic to increase to the right. I would like you now to also expand your weak side. This is a weak point and weak side towards the left side. And we manage and we check. They correct the lumbar, they correct the thoracic, they need to find the most correction, lumbar to the right, thoracic to the left, without movement, without any compensations. Now, in order to assist, or let's begin by saying, the patient will emphasize, or we will also guide them to emphasis, and they know that their lumbar is the primary curve. They will know and do more lumbar than thoracic. 1. 2, the lumbar is usually more stiff or more, I want to say, taking more of this trunk in terms of the region of it or the length of it or the curve of it. And many times the length, because there is a lumbar there, the thoracic above doesn't have so much room, like if it's only a 3C or a 3-4C without lumbar for sure. Here we have a lumbar, and then whatever room left for thoracic to develop as the 4C curve, it's not as much as the size of a 3C, let's say, thoracic. So we have generally a shorter thoracic, let's say. And it's not enough for me. I put all my emphasis on the lumbar. Now I need to make sure that the thoracic will not stick out to the right. I need to expand the weak side. It's very useful to give to this short, less emphasized, or this thoracic region, weak side. Let's give it a vector. Let's give it a pull, help from outside almost. This shoulder traction will come and will assist the weak side expansion in a little bit diagonal way, because that is how we're expanding the weak side. We need to lift the ribs. We need to go in a diagonal way. And this is the purpose, basically, of the shoulder traction or shoulder counter traction on the weak side. It is basically in order to correct the compensation of the main thoracic that comes from working the lumbar. So this is very important. If there was no lumbar from left to right, I will not be worried about the thoracic increasing to the right. But it is, I have the lumbar, I push the lumbar, and then I risk the thoracic to go to the right. Then I need to expand it. Hey, thoracic, go back to the center. Expand the weak side. Oh, it's hard for you to expand because you are maybe short, maybe you are... Okay, let me give you an assistant, shoulder traction. So this is really the correction to the number one compensation here on this area. And we call it at the end, shoulder counter traction on the weak side. But it starts from it starts really from the lumbar correction. From the lumbar correction. Then comes the shoulder traction that needs to correct the compensation that will appear in the thoracic as a response to the lumbar. Okay. Here, the second compensation could be now exactly as we saw on the 3C and the 3-4C. Now we are climbing up and we're looking at the thoracic region. If the patient is going to do too much correction of the thoracic from right to left, with this shoulder traction on the left side, we can see the same compensation in the thoracic region we saw. The ribs will fall down. There will be like maybe a creation of a banana to the left. I didn't paint it. And we may see the upper thoracic coming up. Same as before. So in order to lift the ribs and correct the upper thoracic, we will do the shoulder counter traction on the thoracic prominence side, the orange color. So this is the story about the compensation and the shoulder traction, shoulder counter traction. Again, if you are managing the patient well, moving the lumbar from left to right, expanding the weak point, axial elongation, keeping the body square, not letting the thoracic on the right side to increase, and not letting later an upper thoracic If you manage it and always see that your patient is fully looking like this yoga block, rectangle, expanded, parallel lines in all direction, then you're doing a good job. And this shoulder traction, to tell the patient to do the shoulder traction, it becomes less important because you are able to do it without even naming and telling the patient shoulder traction, counter traction, elbow against ribs, or anything. If you see that with your patient, as you increase the muscle activation, coming to the tension of 12 time, the patient is doing their maximum in the lumbar, maximum in the thoracic, and maintaining the curve just like that here in this picture. No millimeter of rib falls, no millimeter of upper thoracic creation. Then you are doing a good job without, again, saying this and this and this and that. So in a sense, to teach these, to understand these shoulder counter traction right and left, is to understand the compensations that we see day in and day out with our patients, because they create this compensation from either mismanaging by the therapist, who is not aware of this compensation I just described, and by the patient who enthusiastic but doesn't get the correction from his therapist, and then this is it. But if you know that these vectors, you understand it, I really don't care that you don't, I don't mind that you not really knowing what belongs to what. But at the end, it really makes sense. If you climb and you look now over this coloring, you will see the yellow is the lumbar. Lumbar, or we call it the weak side shoulder counter traction, the need for it comes from the lumbar correction, expansion, and then a collapse, or the ribs or the thoracic will increase on the right side. And then you need to open the weak side, assisted by this yellow shoulder traction. So that's it. When lumbar, go to left to right, and we may see increase in thoracic curve. In order to assist its opening, I give the shoulder traction on that same side, left, yellow. And then, but because there is a response to this expansion of the thoracic, at time we see, sorry, not this one. At time we see that the ribs will collapse once I start to expand now the thoracic. I'm using this shoulder traction on the weak side, and I see the ribs falling, and I see some creation of upper thoracic, and I need to say, hey, don't over traction to the left side. Now I need to introduce this shoulder traction to the right. Let's level the upper thoracic, and let's maintain the main thoracic level, ribs. So always, 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 shoulder counter traction on the right side, on the thoracic prominent side, in this case is in the right, always is to take care of the ribs that were falling down from overexpansion of the thoracic to the left, and the upper thoracic to stay level without upper thoracic creation, all in response to what's going on in the thoracic, any compensation happening. That's the shoulder countertraction on the thoracic prominent side, belong to creation and compensation because of thoracic activity. And the shoulder countertraction on the weak side, the yellow, is shoulder countertraction, basically vectors, correction, activation, managing the lumbar and the thoracic in response to the lumbar.
That's great, Hagit. I think we're going to stop here today. We have a couple of questions. Please keep it in mind that our lecture today is for our SSOL Schroth graduate students. So maybe some of these for terms are not very familiar for you. Can you comment on weak side, weak point? We have a question here, and we wanted to know here, and we don't have the name of the people who are asking, what is the third compensation for the 4C curve? So these are questions from the audience. You can see it also on a Q&A on the bottom.
Okay. Weak point and weak side are the concavities that we have. So if I take this one, I'll just mark the weak point, WP, is the lumbar concavity, and weak side is the thoracic concavity. That's how Katerina and Krista Schroth named the concavities: weak point, weak side. The compensation, the three compensations, sorry, where am I? 4C. Basically, the compensations are, when I describe it right now, the first compensation is the creation, let me just bring it here, the increase in the main thoracic curve. As the lumbar go from left to right, the first compensation I see is increase. I told you, move your lumbar from left to right, feel your ribs coming up. First compensation. In order, just in order of happening. The next compensation is, compensation number 2, with that, let's do it here, with that ribs, with correcting this compensation that happened, that the thoracic went from right to left. At the same time, it's in the same region, I see that the ribs now are going to collapse. So that's number 2. After correcting the compensation, number 1, thoracic go to the right. Then if I do too much thoracic to the left now, I see ribs are falling. So I need to manage that at the same time with the third compensation here, which is the upper thoracic creation, just coming from bottom up. This is how the sequence of event. Then the third, by overcorrecting the thoracic from right to left, we're risking the upper thoracic, and I just name it number 3. It's really, I just created this for this presentation. It's I just gave the numbers as I walk up the occurrence of the compensation. Okay?
Thank you. We have
Yeah.
another question here regarding the third pelvis correction for the 4C. If it is going to cause an increase of the thoracic curve, please explain.
The third pelvis correction is from usually the right side towards the center. So, and we have thoracic on the right. So by moving the lumbar from right to the center, it's usually, I don't experience any connection to the thoracic, not increasing to the right or not collapsing to the left, because immediately we have to manage with opening the lumbar from left to right. So no, not really.
Thank you. And could you give some cues on how to facilitate the shoulder contraction? We have this question, as many adults have been struggling with the position of the external rotated shoulder and the elbow.
Okay. I don't know if you can see. Maybe I'll stop. Okay, so what I usually, I think I have probably mirroring you. So you see this as on your right side?
On
This is,
mirroring. Yeah,
yeah,
it's
so
okay.
this,
We will know. We will know.
right. So both elbows need to be a little bit in front. So don't put them parallel to the like a continuation of the trunk. First of all, bring them a little bit to the front. Now it's very hard. I think each case I need to see what's happening. But on the right side, you may hold the pole and maybe turn your palm. It's one cue that you can do is to turn the right palm actually backwards a little bit, not twisting their wrist, not making them feel uncomfortable. Each person, whatever they can do, of course. But if you may direct it a little bit back, and then it creates external rotation. Or if you put your hand, maybe you can think, what can you do for external rotation? Maybe behind the head if they're lying down, putting the elbows on yoga blocks, somehow that it can create a little external rotation. And the left one, if there is no upper thoracic additional, the left can be a little bit in internal rotation, usually sometimes more in front. So when you take your arm and push it a little forward, it becomes slightly internal rotation. Sometime against the bar, I ask them to push. So they push forward, it creates a little external rotation. Things like that. But that's usually better in a live course to see. Maybe I'll just go to the last.
Thank you. Thank you. Can you just go back to 4C again? We have more questions about 4C to explain a little bit with the pelvis correction and how is it affecting the lumbar correction and what is the effect on the thoracic curve once you created the lumbar correction? How does the thoracic curve is progressing when the lumbar is overcorrected? You were talking about that, and I think we need to clarify that for one of the attendee.
Okay, I think from what I'm hearing, it's repeating basically everything, and I
Not
think
that, not everything. I think
takes
I think it's just you know, bringing everything to midline. I think to create the lumbar correction and then how to be careful with the thoracic. I think
okay.
just repeat that part because it's very complex. It is for our advanced students here. So I know some of the guests and this guest is don't see a name, may not be as well educated in our method.
Okay. So it's a point very good that you said that. If you ask a question, we would like to know, I think, tell us from what school you are, because we need to know if it's not a school that was studying the shoulder counter traction at all, this is not a presentation for you right now, or you can listen to it, but you can, I think, take the recording. As I said, I learned a lot by hearing and listening and looking again and again and again. So I can just progress with the presentation. But as I said it a moment ago, the third pelvis correction is frontal plane alignment from the right to the center. Here she's already centered it. And as she moved the pelvis only to the center in order not to push the lumbar with it to the left. So when we move pelvis from right to left, we have to counteract with lumbar expansion of the weak point from basically left to right. And then we have to expand the thoracic from right to left to prevent from this thoracic to increase because we're pushing the lumbar to the right. And then come the rest of the
Yeah, thank you.
arrows. I will go to the single lumbar, thoracolumbar, because I actually want to get to the second presentation at least today.
I think we do have to stop here today, and we can have a second lecture set up
I
for
think
open
it's 12.
house to make sure that we can cover the full topic. I think we'll try to find a second part time for
Not
May
it 12?
for the open house. Are you able to cover it in the next 20 minutes?
Yeah.
Okay, all right. So let's go ahead for the next 20 minutes and then we stop there.
Okay. The single lumbar and thoracolumbar. Maybe let's see how I proceed. At least I finish this topic. As you remember, the single lumbar and thoracolumbar, I said it's also a primary, of course, lumbar or thoracolumbar, depend where is the apex of the curve. So we aligning the pelvis underneath the shoulders, moving it from right towards the center, stop. Don't move it more because then you will increase the lumbar to the left. It will push it. So just in the center. Then, of course, there is always axial elongation. Then the patient starts to move, focus, emphasis on lumbar correction from left towards the right side, expanding the weak point. As they are expanding the weak point, moving the lumbar from left to right, we unfortunately see that patients starting to give themselves like a thoracic curve. It's really a virtual, it's not, it's a creation, it's a compensation. It's not really, they are single curves. But if you move your body, if you move your lumbar, and do it with me again so you can feel it. Move your lumbar from left to right. Just squeeze your lumbar on the left. You will feel your ribs expanding on the right side. Not just the waistline on the right is open, which we encourage with muscle activation of the QL, but the ribs are starting to expand because the body is at the end is one. So our role is to recognize that I see the ribs coming, the thoracic coming to the right, like creating themselves a thoracic curvature, and I need to do something immediately about it. What will I do? I will do exactly what I did in 4C. I will tell the patient, hey, don't push your lumbar too much to the right. Don't let your ribs go to the right, your thoracic go to the right. Start to expand your weak side. And to assist it, I will give a little shoulder traction on the left side to help. Why do I need to help with the shoulder traction? Why do I need to help? Why can't I just say, expand your weak side? I can say it, but because this is a lumbar, and because we're going to push more emphasis on the lumbar to the right side, and all the time there is this force from the left to the right, and plus the lumbar will probably occupy a larger space, and whatever left in the thoracic that is being pushed to the right, I need something to assist this expansion. Then I bring this shoulder traction, and it's like a hook. Will expand and bring the spine from the right to the center. It's an assistant, this shoulder traction assisting the weak side expansion. Why does it need an assistant? Because usually it's not a large part, or there is more force from the lumbar pushing it to the right. So I need some assistant, and it's very easy with the shoulder traction to return the thoracic towards the center. The muscles also, this latissimus dorsi, will expand the ribs, and it's attached to the arm, so it's really pulling the spine to the left. Okay, very good. We could have stopped here, but unfortunately, and this is the beauty of this work, is that you give full force lumbar. Ay, 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 you got a compensation of the thoracic. Give full force on the thoracic. But sometimes we see a compensation now of ribs falling down and upper thoracic creation by overdoing shoulder traction to the left. So I will have to do the same thing that I described to you in the last three curves. When it comes to the right side, shoulder counter traction on the right side, we'll lift up the ribs, we'll return the spine from the left to the right, we'll return this upper thoracic number 3 from the left to the right, and maintain the trunk elongated and expanded in all directions. And this is the template for this. Okay, so I think I will go to this radiological curve type. We'll do this presentation. It's not long and it's nice. And it's going along with what we did now. That's why I think it will be great and could have, yeah. We have the 4 curve types, okay? And we named, I'll just take this, and for those SSOL, this is 3, 4, C. The same as non-3, non-4. One second. Wait. Okay. What do we see here? The 3C curve type, primary thoracic, have 3 subtypes: A1, A2, and A3. Remember that a 3C is a primary thoracic curve. A1 and A2 have no lumbar. We can even say that this is a single major thoracic. A1 is a long, single, long, as you can see here, thoracic. Usually the transitional point, the apex is low, meaning it can be from T9 to T11. It's low. We see, very important, is to put lines over the vertebrae of L4 and L5, L4 and L3, and see the direction of L4. Also good to see L3, but at times, but L4 right now. And I see that the direction of L4 is in the same direction of the whole bottom of the thoracic curve, basically. So we have here one long thoracic curve low, because the apex is low, coming down really to L4 is in the same direction, even rotated. And here I think she have also an upper thoracic, but right now it's not important to talk about. So this is a type that does not have a lumbar. The thoracic go all the way down to the pelvis, many times even rotated in the last vertebra, L4 or L3 as the last vertebra, and then L4 coming back. But here I think it's also rotated. And it's a particular, a unique curve type, but it's actually very easy to correct because it's all in with rib cage and pelvis, and you can correct it with the good with bracing. A2 curve type, A2, is where L4 horizontal. So if we're looking at here, we see that L4, really also L3, are horizontal, leveled. They are not participating, but also there is no lumbar curve here. We see that the lumbar region is crossing a little bit the central sacral line, which I think actually can move it a little. This is more precise. The vertebrae are a little bit to the left of the central sacral line. So sometime if it's a really beginning of scoliosis in a patient, maybe it will form a lumbar a little bit later or later, maybe not. I don't know. I'm not sure. I will manage, I will monitor, I will observe it, that nothing happened to this lumbar. Me and the orthotist. But basically, we naming it as A2, also major, almost a single thoracic without a lumbar, maybe a functional will come or we'll see. This A3 type, this 3C type is A3, meaning we see that L4, also L3, are in the direction of creating a lumbar curvature. Not in the direction of the thoracic like this one, not horizontal, but yes, now we see there is a lumbar. One of them will be the lower end vertebra, probably number 4. So we have a lumbar curve, we have a thoracic curve. Transitional point is to the right side. That's why we name it a 3C, of course. But you see that really one type out of the three subtype of 3C having a lumbar. So you can see that I really don't need to emphasize much on lumbar correction in 66% of 3Cs, and really just focus on thoracic, maintaining, managing good lumbar stability, and shoulder counter traction will be on the right side because this patient basically will really going to move their spine from right to left. And then we expected to see a mirroring effect, drooping of the ribs, upper thoracic creation, like I was just telling you about the compensation. So we will basically need to know for each subtype, what is the best correction during exercises? You know that sometimes we take the curve here. This is the patient, a 3C, with the pelvis and lumbar to the left and thoracic to the right. And when we creating the corrections and guiding the patient, we don't want to see number A. So this is No, we don't want to basically create a mirroring effect. So if I'll take this, I will cross it, and I really don't want to have this type of correction. And then the question, is it maybe good enough to correct a 3C, to have the pelvis under the trunk, under the shoulders, like, bringing a patient to be good centered correction? Or should we go further and do a diagonal, a resultant diagonal traction line from overcorrecting of the pelvis from left to right with elongation and allowing this diagonal traction line and overcorrection to be created? This is an important question. But before I will answer that, I will go, I think, to the sister, what I call the sister of a 3C. I will go to the 3-4C, or as known as a non-3, non-4 in BSPTS. So the 3-4C, the balanced curve with a transitional point in the central sacral line, they have also two options. Some will have the no lumbar. You can see that L4 is horizontal. And some will have a lumbar curve. We see that L4 is tilted towards the direction of the lumbar. So this is C1 type. This girl, we see the transitional point on the central sacral line. Her L4 and L5 are horizontal. Maybe they're a little bit towards the left side if I did it. So maybe something will come, but right now, no lumbar curvature. Usually you can also look if they are rotated, and they are not. This next type, the C2 type, having L4 and L3 tilted, not horizontal. And you can see, of course, a lumbar curvature, very clear and easy. So this is the second type of 3-4C or non-3, non-4, basically. And as I told you before, when we're managing a patient like that, we really just need to keep lumbar and pelvis stable, and by the axial elongation or the traction belt in certain exercises, or the axial elongation when you don't put a belt or with a belt, then whatever lumbar correction you get is enough. You don't need to emphasize more on lumbar, but emphasize more on the thoracic curve. Just manage that the lumbar will not get worse. And this is another, sorry, where is she? C2, okay. I'll go to the 4, this is 56. So I usually, when I describe in classes, I describe 3C and the 3-4C more as sister to each other, because they're also practicing only shoulder counter traction on the right side. They are primary thoracic. They can have or not have a lumbar. So they are pretty similar in this manner. The next will be the two brothers, 4C and the single lumbar or the single thoracolumbar. And each one of them have of course, a lumbar. The 4C will have a thoracic, and the single will not have a thoracic. In both of them, we have two subtypes. One of them is going to be under the name B1, and the second one in the single is E1. It doesn't matter, but it's the number one that represent here that the apex of the curve, the lumbar curve, the primary curve here, the apex is below L1, also here. So typically, apex of lumbar is L2, maybe the disc between L1 and L2, sometimes the disc between L2 and L3, but L2 is the average apex for lumbar curvature. Like T8 is for thoracic. Oh, this should be here, and this should be here. Then the B2 type for 4C, similar to it, a name called E2 for single, meaning it's the same curve of its brother subtype, just where is the apex? So in 4C, if the apex will be between T12, including T12, to L1, including N1, and the disc between them, then it is called a B2 type, meaning the curves are higher. The lumbar curve is higher. It's actually a thoracolumbar curve. And then it will have a higher thoracic curve. You can see the apex here is higher than on the left side, the B1. So this curve type basically is higher. It's rare to see, for example, upper thoracic creation of curve, upper thoracic, the D modifier that you see here, can come with 3C curve, 4C curve, 3-4C curve, not really with a single. It cannot just all of a sudden appear here. And if we're talking about the upper thoracic, then 4C that have both lumbar and thoracic curve usually have less incidence of having a 3C, having an upper thoracic curve, particularly the B2 type that already have higher main thoracic. Almost there is no room to fit a third curve or a fourth curve, we can say upper thoracic. But it may exist. It may exist. Then it's not easy to manage. There's going to be basically 4 curves here: upper thoracic, main thoracic, lumbar, and then the fractional lumbar sacral curve. That's why it's named 4C, because there are 4 curves, even if they're not fully, but 4 curve in the road of the spine. It is more common to see an upper thoracic curve with a 3C and with a 3-4C. Because, and probably more with an A1 type, because with A1 type, the main thoracic apex is low, and there is enough room to develop a curve to the left in the upper thoracic region. It's all about, spaces, compensations, yeah, to think even in this way. And also, yes, also the 3-4C will also can develop. The less common to develop is a 4C, and not to develop is a single. So you can see that the single also primary lumbar. It's going to be E1, a single lumbar, if the apex is below L1, as I said, typically L2, or it will be a single thoracolumbar, E2 type, subtype, if the apex is between T12 and L1, higher. And sometimes this really occupied the whole body. So let's view it for a second before we finish. B1 type. We see here transitional point to the left. We see thoracic curve and lumbar curve. We look where is the apex. And the apex here is actually the disc space between L1 and L2, below L1. So this is going to be a B1 type. This one, we see that the same thing, transitional point to the left, there is thoracic, there is lumbar, and the apex again is disc between T12 and L1, disc space. So because now it's between T12 and L1, this is going to be a B2 type. Thoracolumbar in the lumbar region and main thoracic a little bit higher. And in according to that, or to all these subtypes, basically it is really made, this subtype, more for orthotists. When they, and you know that Rigo makes the Rigo bracing, and the orthotists need to be super precise where they put the pressure points. And sometimes they need to put it below the vertebra, sometimes they need to put it on the vertebra. Depends on the apex location. So they need to really know the differences between one vertebra and is it a lumbar or a thoracolumbar? Is it in the 3C, is it T9, T11, or T8? Is it an A1 type where there is no lumbar and I don't need to put any forces like that? Or there is a lumbar? They must know it. And honestly, I feel like we need to know it as well. So you will have an appreciation. Our rice bags are larger, so they are occupying a larger area. But even though it's good to know, do I have here a single lumbar or do I have here a single thoracolumbar? Do I have here a 4C with a lumbar or with a thoracolumbar? So this is a single lumbar apex at L2. Therefore, it's going to be, it's going to be E1 type, below L1, the apex. And this is apex at T12. And therefore, it's going to be, this is a long thoracolumbar. Many times people think that maybe it is a thoracic, maybe a long, low thoracic. But when you count the vertebrae and you see that it is a T12, you will certainly say this is a thoracolumbar. It's a single. And look, the interesting thing here is that the transitional point always, guys, in a single, generally, transitional point that help us to classify curve types is between thoracic, main thoracic region, and lumbar region. There could be other transitional points between curves, but for curve type, I want only this one between the thoracic region and the lumbar region. In this case, the lumbar is a thoracolumbar, and it is long and high. So the transitional point will be high, almost in the upper thoracic. So it is high. Don't put the transitional point below. because it needs to be between the lumbar region, or in this case, thoracolumbar region, and whatever left from the thorax. So this is a E2 type. Apex is a T12. And when I go back for a moment to the A1, to the 3C, 3 subtype, I want to say, and you should experience that from now on, maybe from this lecture, an A1 type usually is preferred. I will actually do it this way. If you see, it's a one long thoracic, and there is no lumbar here. The yellow arrow coming down telling us that the thorax is being pulled down towards the right pelvis. I'm actually going to take this away for a moment. The thorax is being, this is not a weak point per se. There is no lumbar curve here. So there is no weak point here. This is a collapse below the main thoracic, is a collapse of the ribs down and the muscles here. So you can, in a sense, say that it is being held down towards the pelvis on the right side. From experience, this type, and you need to look at it on X-ray with your patient, otherwise you can also do scoliometer and see that there is no lumbar prominence, but it's very good to confirm with X-ray. If you put or move the pelvis too much to the right, or put the belt maybe to the right side rather than the center, you can put 3C in the center. And maybe this curve type, if you pull the pelvis too much to the right, just imagine now, I push the pelvis overcorrecting to the right. What will happen to the right thoracic that goes all the way down to the pelvis almost? It will increase by the pull of the pelvis to the right. And then you will have a hard time managing getting the thorax to go to the left. So in this particular curve type, subtype, it's preferred actually to put the belt in the center, not to overcorrect the pelvis, just to bring the pelvis probably to the center and elongate the spine. You can do a little bit, but you can create a diagonal, but not so much by pushing the pelvis over to the right and the belt over to the right side, because if we do that, it might, as I say, might, from the contraction here, there is a contraction under the thoracic, it will pull the thoracic with it to the right. So we gotta be careful about that. I will jump to the A3 type. Here, it's going to be very beneficial to take the lumbar and the pelvis, or to take the pelvis and push it over correction to the right, because it will take this lumbar from left to right side. Then through the transitional point, the diagonal traction line will be formed. It is not risking the thoracic is higher. And the overcorrection of the pelvis with the belt to the right side of the center of the pelvis will help in better correction. A2 type, you need to see. They don't have a lumbar, but they are also not like this one. like the A1 type. So you can maybe overcorrect. I don't think it's going to risk the thoracic. And you can put a belt on the side. Just see what is best. Looking, this is the key. What is